So welcome everyone to the OLLI Medical Series. This is a weekly series of classes where we bring in doctors from the community to talk about issues that are geared mainly towards the older population. Today we have Dr. Thomas Cesario, who's a professor of medicine in the Department of Medicine, Division of Infectious Diseases at the University of California, Irvine. He is a well-known authority on multiple infectious diseases. Dr. Cesario will discuss the vaccines and their importance, particularly in the senior population, including measles, shingles, pneumonia, DPT, flu, and of course, coronavirus. Dr. Cesario will include updates on the vaccines that are being developed, including the new nucleic acid-based vaccines that use DNA or RNA and cause the body's own cells to manufacture the coronavirus antigen. He will touch on changes in the mature immune system and the need for higher dose vaccines for mature adults.
So I'm happy to talk to you about immunizing older adults. I'd like to begin by just telling you that we've had vaccines now for a little over 100 years. The first vaccines, as we really know them, came on the heels of a discovery in the late 1800s that certain bacteria like tetanus, for example, diphtheria, whooping cough, produced toxins. And so it was appreciated that you could harvest these toxins from the bacterial cultures, modify them a number of ways, heat would be one, and still maintain their immunogenicity, still allow people to develop an immune reaction to the vaccines, and as such, become immune to the ravages of that disease. The first vaccine, to my knowledge, that was really widely used was tetanus, which was used for the first time in World War I. As you can imagine, tetanus or contaminated wounds would be a scourge during war, which it had been up until that time. And it was appreciated that year in the 1900s, I think 1915 to be exact, that when they began using this immune vaccine, that the incidence of tetanus dropped significantly. And since that time, we've capitalized on that thought to develop vaccines to many different infectious agents and different toxins. So this is a list of the commonly used vaccines that we have. And a lot of these vaccines are basically vaccines that we give to infants. So they start life already protected from some of the serious ravages of diseases that many of us were aware of in our lifetime. And many of us actually were afraid of some of these illnesses, like polio, for example. But certainly diphtheria and pertussis. And we'll talk about some of those diseases and what they were like and how the vaccine has radically changed how we have reacted to those different agents. So this is just a list. We're not going to talk about all of these vaccines because a lot of them, as I said, are pediatric vaccines and not relevant to us as we age. But perhaps the first ones that we do want to talk about are those that are relevant to us. And I like to include about a half a dozen of those. And those include the vaccine that we use to prevent tetanus and diphtheria and pertussis, shingles, which is the medical term of the course is herpes zoster, influenza, the major pneumococcal vaccine, which is the major pneumonia vaccine, which is of two types. We'll explain why we need the two different types. And finally, we'll talk about the coronavirus vaccines. I don't intend to cover them, but if there are particular questions, we could come back and discuss some of the unique vaccines that we ordinarily wouldn't get as older adults, but in certain circumstances, we might need. And what are those circumstances? They would largely be cases where there was a big outbreak or somebody for some reason had not developed immunity for some reason, had not gotten the vaccine in childhood, had never been exposed to it. There may be occasional cases like that where we would want to give somebody who's an older adult what amounts to a pediatric vaccine, or a vaccine that would normally be given at least much earlier in life. And finally, even the travel-related vaccines like a yellow fever, for example, which are unique, which are used in very unique situations and not generally applicable to all of us. So let's begin with tetanus, since that's probably the first vaccine that was available. And let's talk about the tetanus vaccine. Tetanus is a disease that's caused by a toxin. And when you think about it, whenever you move a muscle, let's say you move your arm towards your chin, your body has to have a way of stopping that movement, or you would inadvertently strike yourself in the chin. So as you move in one of your muscles, simultaneously, there is put into place an inhibitory neuron, an inhibitory action that stops you from striking yourself. So you have a positive reaction and a negative reaction that controls your movement very carefully. Now, what the toxin of tetanus, which is caused by a bacteria that we call Clostridium tetani, it inhibits that inhibitory message. So you can't stop. So you move your arm and the arm goes into spasm and it stays there. And that's the disease we call tetanus. In years past, that was a relatively common disease, hundreds of cases. It usually was a disease that occurred because a wound would get contaminated with some type of material in the soil in which there were spores, the spores of the bacteria that produce the toxin. So when we had the toxin, we couldn't prevent that catastrophe from happening. Furthermore, if you got that disease where you had these terrible spasms, it eventually would lead in many cases to your death, because you would be unable to eat, you would waste away, and ultimately you would die of it. And as you can see, the disease would last about, well, actually last months, but it would take about a week before it would actually get into full swing. And then you would get these very painful muscular spasms. You would have an associated component of what we call your autonomic system, that is sweating, for example, things of the rapid heartbeat, things of that type that would go along with it, that ultimately would lead to a fatal outcome. Now, we know that the disease has been modified because almost all of us receive this appropriate immunization early in life. So whereas in the past we had thousands of cases, each year in the US, we have less than 50 cases a year of tetanus. Who gets it? People who haven't been immunized, or conceivably who have not kept up to date with their immunizations. We say we should probably update this about every 10 years. And if you have a recent wound, depending upon its nature, then we give you a booster in a shorter period of time, 5 years, or in the worst cases, in a really bad wound, in 2 years. We don't give it more often because you can react to the vaccine and you develop a painful, swollen, reddened area on your arm if you get too much vaccine and you overreact to it. We give this vaccine typically in childhood as a combination of tetanus, diphtheria, and pertussis, which is whooping cough. But the only thing we really need to keep up as we age is the tetanus and the pertussis. Why? Well, tetanus, because we're afraid of the disease. Diphtheria is very rare in the US. We have less than 1 case a year that we know about. And so we have effectively eradicated that disease. On the other hand, we know whooping cough still is with us. We know that there have been times when we have had tens of thousands cases of whooping cough in the US. And we didn't really recognize it because in adults, whooping cough is just that, a bad cough. It's in very young children that you get these terrible coughing spasms the children on coughing, and they actually get brain damage because of a lack of oxygen. So we call that anoxic brain damage. So what we do is we keep giving you the whooping cough vaccine along with the tetanus vaccine, not because we are worried about you, we are worried about you giving it to a child, and particularly your grandchildren. And we've learned that painfully over the last 15 or 20 years that whooping cough immunity declines very quickly within a few years after you get the vaccine. Even the natural disease doesn't give you permanent immunity. And so, how we have maintained that immunization and that immunity is to couple the whooping cough vaccine with the tetanus vaccine. And so we give it as TD. And in recent years, it's been very hard to get TD alone. So we actually give it to you in the adult vaccine, which we call Tdap for tetanus, diphtheria, and pertussis. But it's a modified dosage than we give in children, particularly oriented to adults. And we do that in a modern vaccine, which has been purified to eliminate some of the contaminants, particularly the contaminants associated with the whooping cough vaccine that we thought was causing a certain amount of problems. So this combination, this Tdap, is what we give you hopefully every 10 years. It protects you against tetanus, and it prevents you from infecting others with the whooping cough bacteria, which in a child less than one can be a catastrophic disease, particularly under 6 months. This is what tetanus looks like when you get these terrible spasms. You end up arching your back. We call that opisthotonus. And this profound spasms keeps you in this position, which is very painful for when it goes on for an extended period of time. So this is the vaccine. Early on, it's a 3-dose regimen, and then you get routine booster every 10 years. And we talked about the fact that this vaccine is a toxoid, meaning you're not getting the whole bacteria as far as the tetanus is concerned. You are getting a modified toxin that the bacteria produces, and you also get some fragments of the whooping cough bacteria that allow you to develop immunity to the whooping cough as well. All vaccines induce an immune reaction, which is beneficial. Now, sometimes when your immune system reacts, you more or less overreact. And so the most common problem with vaccines is a local reaction. That is, you stick the muscle in the arm, and the person is going to have a sore arm, oftentimes a little red for usually 24, 48 hours, and then it goes away. If that's severe, you can get fever with it, usually for 24, 48 hours. And some people will get aches and pains, which are the arthralgias and nausea. And because of the old components of the whooping cough vaccine, there were older people who particularly would have things like a seizure. We never really were sure if it was related directly to the vaccine, but we were concerned about it. Nowadays, as I mentioned, that vaccine, the whooping cough component, has been purified, so the risk of getting these reactions is much lower. There are people who can't take the vaccine. After any vaccine, you can occasionally get a very bizarre neurologic reaction, which is a temporary paralysis that begins on the legs and moves up. We call it the Guillain-Barré syndrome, which is very, very rare, usually one case in a million, something like that. But it's very uncommon, but it can happen as a reaction to a vaccine. But it also can happen as a reaction to the disease itself. So it's not unique to the vaccine, but it's always something we say it can happen, even though it's extremely rare. So let's move now from the 10-year updates on the tetanus vaccine to influenza. You know, we have influenza with us every year. And influenza is a lot like coronaviruses, which we'll talk about in a second. These are unique viruses that their genetic material consists of RNA. And you remember, to make protein, you go from DNA to RNA to protein. So these viruses are RNA viruses. That is, their genes are made up of RNA. They have no DNA. Now, when you have an RNA virus, there are things that are very unique. And one of them is they lose the ability to edit the gene. What does that mean? That means as you keep copying these genes billions and billions of times, mistakes happen. Now, when it happens in your body corrects that. It recognizes the mistake, throws out the mistaken RNA, and you go on from there unaware of what happened. But the viruses don't have that, these viruses don't have that ability to correct that mistake. We say they don't have an editing function, so that the virus keeps changing because the mistakes keep getting incorporated. Most of those mistakes don't matter, but every once in a while you get one that does matter, that makes a difference. How infectious it is, how effective last year's vaccine is going to be, etc. So influenza is notorious for that. So we know the influenza virus changes every year. It comes back every year, and every year it comes back in a different form. It's a very infectious virus. We say that for every one case of influenza, there is somewhere between 1 and 2 other cases directly attributed to the first case. So it's fairly infectious as we go along. The most infectious virus is measles. For every one case of measles, there will be 10 to 18 secondary cases. That's the most infectious virus that I know of. But influenza spreads very quickly. When you come in contact with the virus and you're susceptible, it takes only 1 to 3 days before you get sick. We call that the incubation period. And every year this virus comes back across the world. The US is no exception. And every year in the US, somewhere between 5 and 20% of the people will get influenza. Periodically, usually about 3 times in a century, we will get a new strain introduced. And when that happens, you get a lot more cases, and that's when we call it a pandemic. Epidemic is a limited outbreak. Pandemic means everybody gets it. In the US, every year, without a pandemic, we have at least 200,000 people who get hospitalized directly related to influenza infection, and about 35,000 people who die every year. 90% of those deaths are in people over 65. That's why we are particularly anxious to immunize our seniors. Now, when we get those pandemics, oddly enough, and the last one was in 2009 with H1N1, when you get those pandemics, the mortality shifts, and then you get more young people dying. But in the average year, it's the people over 65 that are the greatest risk. Influenza as an illness by itself is not a particular problem. You get fever, runny nose, cough, aches and pains, a lot of muscular aches and pains. That's characteristic of influenza. Usually it will last up to about a week, and then it will go away. The peak virus titer, that is when you have the most virus that you're excreting, is about day 2 of the illness. And that's when you're most infectious to others. And usually that infectivity is pretty much gone by the end of the week. That's when you stop being able to spread it. We know that the influenza virus does a lot of things. One of the things it does is it removes the little hair cells on your respiratory tract. And when that happens, those little hair cells are responsible for sweeping bacteria out into the environment. And if you can't do that, you become uniquely prone to a second bacterial pneumonia. So bacterial pneumonia is the most common complication of influenza. On rare cases, you can get viral pneumonia. You get the virus itself causes inflammation of the lung, and that usually is a more serious complication. And while we have treatment for it, the treatment is not as efficacious. So the mortality rate is somewhere in the 10 to 15% range of viral pneumonia. But as you can see, you can get complications that involve other organs of the body, the heart, even sometimes confusion. And as you see, a Guillain-Barré is there. Again, always very, very rare. This, as you know, a famous slide from the 1819 pandemic being now reproduced with the coronavirus. We do have treatments for influenza, and they are pretty good. The problem is you have to get there very early for these treatments to work. As you look down that list, you'll see oseltamivir, and all of you know that as Tamiflu. The others are peramivir is something we give IV. Baloxavir is the newest agent and not used very often, reserved for cases where we think person might be resistant to the drug like Tamiflu. Now, we know there are different strains of influenza that circulate in the community. And we know that the part of the influenza virus that to which you develop immunity is the surface of the virus, that there are projections from the surface of the virus that allow the virus to stick to your cells. And that's a very specific interaction, that process of sticking to your cells in your respiratory tract. We call those spikes the hemagglutinin, because those spikes will, in presence of red blood cells, we'll call them the clump. But all those spikes those are the component that allow the virus to attach. But we also know that hemagglutinin is important to your immune system, because if you develop antibodies to the hemagglutinin and to a second component on the surface that allows the virus to release itself, we call it the neuraminidase, then you are immune to that infection. Now, we know that there are at least 18 different types of hemagglutinins in the environment, and we know that there are something like 9 different types of neuraminases that are out there. And so you can develop the permutations, and you can say that if you mix this hemagglutinin with that neuraminidase, you get this particular virus. So you can literally end up with tens of different strains of influenza. So each year we predict what is going to be the dominant strain. It very often is a variation of the strain that was present last year because of the mistakes the virus is making. But every once in a while, 3 times in a century, you get a whole new strain that has a different hemagglutinin or a different neuraminidase, and that's when we get a pandemic. So what you get every year when we talk about influenza is the best estimate that we have of what is going to be the predominant influenza strain this year. And we usually guess in such a way that we predict not one strain, but usually now 4 different strains, because they're different types of influenza. We call them A, B, and C. So we pick those vaccine strains depending upon what we have heard from around the world that's the predominant strain. And then we take that strain, we grow it up in eggs, and we use that egg-grown virus as the vaccine, mindful of the fact that you're dealing with a vaccine that has a combination of 4 different viruses, any one of which we think could be present in this current year and infect you. Usually we take that virus and we inactivate it. We inactivate it with a chemical or with heat or something, and what you get is a dead virus. We do have, typically for children, a live virus strain that is what we call attenuated, meaning the virus has been grown in such a way that it loses its ability to cause an illness, even though it can infect you. But in so doing, as it infects you but doesn't make you ill, it immunizes you. We typically don't give that to seniors. We give the inactivated vaccines because there have been studies that showed in general that it's a little bit better. But because this virus changes every year, you have to get a new immunization every year. And we know that older people don't respond as well, so we do a couple of things. What is important to us is that as you get older, your ability to respond declines. In the average year, the vaccine is somewhere 30 to 70% effective. What does that mean? That means if you expose 100 people who have been vaccinated, you will prevent disease in somewhere between 30 and 70 people. That means there's still people who, even though they got the vaccine, are still going to get the disease. So it's still not perfect. And that varies with how good the vaccine is. If we didn't guess right, that vaccine could be 10% effective. And that happened in In 2017, we got a vaccine that was not very good. And the fact of the matter is, most people who came in contact with the virus got it. Now, that in mind, with the fact that the next thing that happens is that we as older adults don't respond as well. So what we do is we have a special vaccine for us that has 4 times as much viral antigens, 4 times as much of the appropriate component of the virus to which your body will react. And we give that to people who are over 60. So that's the high dose vaccine. The other way you can do it, and that vaccine has pretty much been proven to be more effective and to give you better antibody levels. So you always ask for the high dose vaccine. The other way to help adults is you add a component to the vaccine that we call an adjuvant. And what that does is it boosts your ability to respond to the vaccine. And that a vaccine, that adjuvanted vaccine, is the second way we help of helping with adults. But in general, I would say get either one. But if I had a choice, I'd probably take the high dose only because I am more familiar with it. So now let's switch. Influenza is a respiratory virus. I told you it paves the way to secondary bacterial infections. And the most common bacterial pneumonia is something we call Streptococcus pneumoniae. Every year in the US, there are several million cases of pneumonia, probably close to 5 million. Half of those are probably virus, like influenza, adenovirus, coronaviruses. The other half are probably due to bacterial, the most important of which is Streptococcus pneumonia. And Streptococcus pneumonia can infect anybody. And it doesn't, you don't have to have a particularly weakened immune system. Many cases follow on the heels of a prior virus infection like influenza that make you more susceptible. You are particularly susceptible if you are somewhat compromised, living in a nursing home, had an old stroke, something of that sort. Makes you a little bit more prone to getting some of these respiratory pneumonia viruses, bacteria. This is an X-ray of the lung. This is what the lung should look like, this nice black area. These are the ribs. This is the heart. This is a clear lung. And over here, you see this white fluffy stuff here on top of the diaphragm. That's basically pus, inflammatory cells in the lung. And that's what we call a pneumonia. And all of this is the same. These are increased markings because of inflammation in the lung. So this pneumonia is common and it increases in frequency as we get older. This bacteria not only can cause pneumonia, but it can cause ear infections. It can cause meningitis if it gets in the blood. So it's a serious problem for us. And we know that there are 90 different types of this bacteria circulating in the community. But the number of ones that we are likely to encounter is a fraction of the whole. Usually it's about 25 types or less that are the ones we are likely to encounter. So if you suction somebody's lung out who has this pneumonia, you see these actually blue little dots in the back of the white and red streaks there. The red streaks are the mucus. The blue dots are the bacteria that we call Streptococcus pneumonia. And you can see it tends to, we say it comes in couplets, diplococci, or chains. You can see little chains that are forming there. It's very typical of a streptococcus. So somewhere out of that large number of 500,000 cases of pneumonia, 5 million cases of pneumonia a year, there are somewhere about 500 million or so that are caused directly to this bacteria. And of course, the older you get, the more prone you are to this. And we talked about the complications that include more serious things like meningitis. If you get meningitis, even with antibiotics, the mortality rate is still very high, about 30%. And in older people, that mortality, particularly if you're compromised, can be higher. With the availability of antibiotics, if you get there early enough, we have reduced the mortality from pneumococcal pneumonia from 20 to 30%, which it was before we had penicillin, now to less than 5%. But you have to get there early enough, and we like to prevent the disease before it ever gets to be a threat. And we do that by taking, again, some of the surface components of this case, the bacteria, and turn them into a vaccine. The first of which was the carbohydrate component of the bacteria, which we call the polysaccharide. And we took that polysaccharide from the 23 most common strains, and we made that into a vaccine, which is particularly effective at preventing complications, particularly things like meningitis or blood poisoning, and has some effect on reducing the incidence of pneumonia. Although in some of the people who need it most, like our chronic lung disease, our older patients, that efficacy is probably significantly reduced. The other problem when you give a vaccine that contains only carbohydrate is that you don't get long-lasting immunity, so you have to repeat it. So what we have done is we've taken this polysaccharide and we add it to a modified component of the diphtheria toxin. That gives you a protein carbohydrate combination, and to that you can develop long-term immunity. We say memory T cells. So we have what we call the conjugated vaccine, conjugated to the diphtheria toxin, and the polysaccharide vaccine. And we like you to get both of those, but you have to separate them by about a year. So we like to give you the protein vaccine first, which is only 13 strains. And then the following year, we want to give you the polysaccharide vaccine that gives you 10 more strains. Someday that may change, but that's how we do it. And that is a vaccine that I would encourage everybody to get. So that's the pneumococcal vaccine that comes in the two forms, the polysaccharide and the protein, which is the polysaccharide is called Pneumovax and the protein is called Prevnar. Particularly over the age of 50, you are more prone to this, so that's when we want you to make sure that you get it. And the reactions are pretty much similar to what we had with influenza. So we're going to go on now, and this is the protein vaccine, the conjugated vaccine. I want to say a word about shingles. Shingles is very common, and it is related to two things. One, it's caused by the chickenpox virus, which you are infected with universally early on in life, that lies dormant in your system. The second thing is, as you get older, what holds your chickenpox vaccine in check is what we call cell-mediated immunity. That is components of your white blood corpuscles that attack and destroy virus-infected cells. That cellular immunity declines as you get older. Never to the extent like you get in a disease like AIDS, but it does decline. So we know that there are diseases like shingles that you are much more apt to see in an 80-year-old than in a 20-year-old. What's the difference? 80-year-old is probably 10 times more prone to get this disease than a 20-year-old, and that's a spectrum. So every year you get older, you're a little more likely to get it. Problem, of course, you know, is it's a rash that's very, very painful, and the pain can go on for a long time, what we call post-herpetic neuralgia. Even though the virus clears up from the skin rash goes away, the pain in the nerves can still last for a long period of time. The numbers that you see here are related, again, to the fact that age makes a difference in how likely you are to get this. By the time you get to be 85, there's a 50-50 chance you're going to get this unless you've been immunized. This is what shingles looks like in its most active form, herpes zoster, as we call it medically, usually on the chest, but it can occur anyplace. Talked about the pain that comes with it. Other complications are these things get infected with bacteria like streptococcus or staphylococcus. And in certain places, it can also affect deeper organs. If you get it on the face, it can sometimes affect the brain. So it can become a serious problem. The older vaccine, the original vaccine, which we call Zostavax, was just the old chickenpox vaccine concentrated 16 times. And when we did that, we cut the chance that you got shingles down by about half. But we were never really completely happy with that. Again, the allergy was the same type of components, But this vaccine originally was a live virus, which meant you had to be careful giving it to people with a very weak immune system, like some of our cancer patients. So we have a new vaccine that's been out now for about 5 years that we did what we did with influenza. We took the surface of the virus and we peeled it off. And that surface is a combination of a carbohydrate and a protein that we call a glycoprotein that is necessary for the virus to attach to your cells. And we just took that without the rest of the virus, so it cannot give you shingles because you're not getting the whole virus. And that has turned out to be a very effective vaccine. You have to get 2 doses separated by 2 to 6 months, and you can get some issues afterward. Usually it's fatigue, maybe a little bit of fever. You feel like you're coming down with something. Lasts about a day. And that's very, very common, but it does go away and usually doesn't leave you with any residuals. And that vaccine, as far as we can tell, is very, very effective. And we don't know exactly how long it's good for, but we think it's probably good for at least 10 years, if not longer. So that vaccine is called Shingrix. It's the latest of the shingles vaccines. I'm not going to spend too much time on the other vaccines because I want to leave time for the COVID vaccines, which is what probably you're most interested in today. I want you to know that there are many, many people working on COVID vaccines. There are over 200 vaccine candidates across the world that are being tested, and almost every country in the world's got a vaccine candidate. And while that's a little bit of exaggeration, it's not much. But all these vaccines are different. There are different ways to produce the vaccines. Okay. And this is a slide of some of the different ways to do that. Now, the traditional way to produce a vaccine against a virus is very simple. You either take the virus and you heat it, or you chemically treat it so that it's no longer infectious, and you give that as a kill virus vaccine. Or you pass that virus repeatedly in tissue culture over and over again, so it loses its potency. It maintains the antigenic structure, that is the component to which you develop immunity, but it loses its ability to make you sick. We call that an attenuated vaccine. So that's the classic way we make vaccines. However, there are probably 10 different ways that we are making coronavirus vaccines. There are the classic ways. Inactivated vaccine, largely done in China, not done much elsewhere, but China has several candidates that are inactivated vaccines. But we've tried to short circuit it. We said, look, one of the things we can do is, why are we giving the vaccine? Why don't we just give the viral genes, insert it into you, and let your body copy the genes just for that protein that we're interested in, the protein to which you need to be immune, and you won't get the whole virus. You'll make the virus protein from the gene, and you'll be protected. So we could say we can give you the RNA, this is an RNA virus, or we can modify the RNA, copy it into DNA, and we'll give you the DNA and make the viral protein. And that's what we have done. We're going to come back and talk about those vaccines. We'll talk about why we did it and why they are useful. But there are other things you can do. You can say, well, wait a minute. Why are you giving me the gene? Why don't you just give me the protein? And we've done that too. So there are protein vaccines. Again, all they are is the protein that is responsible for allowing the virus to attach to you. And if we give you that protein, it fools your body into thinking it's seeing the virus, and it makes an antibody and a cell-mediated immune response against the virus that protects you, even though it's only seeing that protein. And there are a few other tricks that we can use as well. We can take a virus that cannot make you sick and modify it so that it expresses on its surface the proteins of the coronavirus. And then we give you this fake virus, and your body is fooled into thinking it's dealing with the coronavirus, and it builds immunity to the fake virus, and so doing, you become protected from the coronavirus. And there are different ways that we can do that. We can do that. Some of these fake viruses that are able to replicate in you, and others that can't replicate in you. So varies, the strategy varies. But basically, what I'm trying to point out to you is there are different strategies to produce the vaccine. So what do we have? Well, the ones we have are the RNA vaccines. And this is a new technology. It's been around for about 10 years, but we have never used it in a mass vaccine campaign before. We've used it in maybe a couple thousand cases for diseases like Ebola that we were experimenting with, never widely used it. The Ebola vaccine used today is not an RNA vaccine. What is the reason for using an RNA vaccine? The reason for using it is because you can mass produce it, you can develop it very, very rapidly, and you can make large doses overnight, and you can modify it. In fact, for one of the avian flu strains, the Chinese actually developed the vaccine in 7 days using this technology. So what you do is you take the component of the viral gene. You don't take all the viral genes. You take the component of the viral gene that expresses the attachment molecule, which we call the spike. And you take that RNA, you have to modify it because your body recognizes that as foreign, destroys it right away. So you modify it a little bit so your body has to tolerate it for a little bit. Your muscle cells pick that up when we inject it intramuscularly, and they begin to express the protein. They use that RNA as the blueprint to make the protein, which then is excreted from the muscle cells, picked up by your immune cells, and you develop antibody and cell-mediated immunity against this protein that the RNA was the blueprint for. And it's been fairly effective. There are probably 7 or 8 vaccines like this that are in the process. The 2 in the US that are licensed are using this technology. One is Pfizer. They had about, as you can see, a little under 44,000 patients equally divided. And in the Pfizer trial, we were interested in if you got the vaccine, how many people got COVID and how many people did not. And it turned out that they had 162 cases of COVID, almost all in the recipients, 8 in vaccinees. So big difference. Vaccine looked very good. But we said, look, we just don't care about who gets the disease. We want to know who gets really bad disease, because that's what we're trying to protect. And in this case, there were 10 cases of bad disease, 9 in the placebo and 1 in the vaccinees. But that was just after a single dose. Remember, this is a 2-dose vaccine. And I'm going to show you in a second with the second one that with the 2 doses, it was completely protective against severe disease. So based on this, our government said, we're going to give you an emergency use authorization. We're not going to approve it like we would approve, but you can use it. Go ahead and immunize everybody. And that was the first vaccine that was licensed. The second one, produced by Moderna, the Pfizer vaccine actually was a German vaccine that they were in partnership in developing. But Moderna, which is a US company that is not a vaccine company, Pfizer, of course, makes a lot of different anti-infective products. They made the vaccine using their strategy. They had a smaller number. They tested something like about 30,000 cases, and equally again divided between who got the vaccine and who didn't. And in their case, 196 cases of COVID were confirmed. 185 were in people who got the placebo and 11 in vaccine. But now after 2 doses, they had 30 cases of severe disease. You could think of that as pneumonia. All of them, all the bad disease in people who got placebo, and none in severe disease in people who got the vaccine. The one patient who died got a placebo. Now, we do know you can react to this. And we've had people who develop a severe immediate allergic reaction we call anaphylaxis. There are at least 26 people who have gotten that. But when you're there and you can treat it, you can usually reverse that right away. There have been no deaths to this. All the people have recovered with the treatment within literally an hour or so and have gone on to a normal day. But you do have to watch for this, and you do have to be there, make sure patients don't get it, and if they do, that you are able to respond to it quickly. Now, the hard thing about these RNA vaccines is they're not very stable. So the virus vaccine has to be stored at -70. Now, your normal refrigerator temperature is -20 centigrade. So you have to have a special refrigerator for the vaccine. And that vaccine is only stable for about 2 hours at room temperature. So literally, you take it out of the freezer, you got to give it. Moderna vaccine can be stored at refrigerator freezer temperatures, that is -20, and it's stable for months at that temperature, and it's stable for about 12 hours at at room temperature. And it all depends on how exactly you package the RNA. It's packaged with a fatty component, a lipid component, actually called polyethylene glycol, which is the same thing used as a filler in a lot of your pills. That is probably what a lot of the vaccine reactions are to. They're to the filler as much as they seem to be to the vaccine itself. But that's what we are concerned with. But that wrapping, that polyethylene glycol surrounding the RNA, not only is what protects the virus, but it's also what you become allergic to. That's necessary in order to protect the RNA and keep it viable to use as a vaccine. Now, the other vaccine that's out there is a modified virus. We take an adenovirus, which is a common respiratory virus. They use this one called the adenovirus 26. There are about 40 known adenoviruses that we have discovered. And you take that adenovirus and you insert the genes for the coronavirus spike. And so that adenovirus on its surface has the spike protein for the coronavirus. And so when you give that virus, which is live, it cannot replicate in your system because this virus is actually a chimpanzee adenovirus. So it's a chimpanzee adenovirus that can't grow in you, but you give enough of it that you fool the body into thinking it's getting the coronavirus. And in so doing, you make immunity to it. And we don't yet know exactly how effective this is. In some of the earlier studies, it was not as effective as we would have liked, about 50% effective, which is the critical limit. But it was discovered by an accident that if you give half a dose the first time and then a full dose the second time a month later, you can get up to 90% protection. Those trials are now underway. And what I'm going to tell you is the advantage of this vaccine is it's much cheaper to use. So the Moderna vaccine is about $30 a dose. The Pfizer vaccine is somewhere between $20 and $25 a dose. You can make this vaccine for about $5 a dose. And so probably what's going to happen is in developed parts of the world, you're going to see the more expensive vaccines, but in underdeveloped parts of the world, you're going to see vaccines like this. Okay. There are other vaccines that are out there. Johnson & Johnson has a modified vaccine in partnership with Janssen, which is a different virus. This is a human virus, adeno 26, but the same kind of strategy that was applied with the AstraZeneca vaccine, which was developed at Oxford in England. That is still in testing phases like the AstraZeneca vaccine is. Probably is going to be done within short time, I'd say weeks. It should have its trials completed and we'll know how effective it is, and it likely will be licensed. Same strategy as the other whole virus vaccine was, just a different virus. This is not a chimp virus, it's a human virus. Chinese have done the same thing with another virus. The Russians have done the same thing with a different adenovirus. So all again, different organizations utilizing the same strategy with slight modifications. These vaccines will all be available. I don't think it likely you'll see either the Russian or the Chinese vaccines introduced here because we have similar things pretty much in the pipeline. The protein-based vaccines, which is one produced by a company called Novavax, which is the protein itself that cannot copy, that you can't copy, that has looked very good in the preliminary studies. They are finishing up now the phase 3 trial. Phase 3 means they're testing it in a large number of people, and it's the phase 3 trial that gives the FDA the information they need to decide whether they're going to allow it to be used. But I think you will see this Novavax vaccine introduced. I think you will see it probably within the next couple of 3 months that it will be licensed as they complete their phase 3 trials. And so that will give us another option. I mentioned also, for the sake of completeness, that the Chinese have developed the same strategy we used in the past: grow the virus, inactivate it. They're testing it. And it looks like that gives you a little less efficacy. Those vaccines are maybe somewhere between 50 and 75% effective. The vaccines that we're using now look like they are about 95% effective. And then other people have used the DNA-based vaccines. A company called Inovio is developing that. That has some other concerns with it. You have to use a special device in order to inject it. And whenever we use DNA, we also get a little bit concerned about DNA injected into our bodies and what the implications of that are. So there are a lot of options here, but the ones that have been employed, well, they are a new strategy. RNA ones, which are the two ones that are licensed, Pfizer and Moderna, so far have looked very good. We're very encouraged. The difficulty has been in producing enough vaccine, distributing it, that we can give it to everybody that we would like to give it to. Those problems are being addressed, but it will be a while before we have that completely solved. And our expectations now will probably be the summer before we will give the vaccine, have enough vaccine to give it to everybody we would like. Now, I'm going to stop here because my time is pretty much up, and I want to leave a few minutes for questions. So I will stop and entertain questions.
After 6 days from the first injection of Moderna vaccine, they developed a palm-sized, painful, and warm rash at the injection site. Is this normal, and can they expect the same at the second injection?
It's quite common to get a local reaction to the vaccine. I would say almost everybody is going to get some reaction. Most common will be soreness of that muscle for 24 to 48 hours. It's not uncommon to get a low-grade fever with it, not uncommon to get some redness around the site of the injection. Those are normal reactions. It is likely that the second shot will give you a more severe reaction than the first. We anticipate that. That's something we have to watch for. But I think most of us who have gotten the second vaccine will tell you that the reaction the second time was worse. And if you think about it, it should be, because when you give that first vaccine, you're already starting to develop some immunity. So when you give the second vaccine, your body is already reacting to that vaccine. So it's very likely you will have a more severe reaction the second time. Most of those are low-grade fevers, a lot of aches and pains, intense fatigue, very intense fatigue. That's a common reaction. And headache. Headache, low-grade fever, and fatigue are the most common reaction, plus the local ones, which are the sore arm and some redness.
If someone is taking a immunosuppressant drug like methotrexate for MG, is it still okay to get the COVID vaccine?
You know, we don't have a lot of information yet on circumstances like that because in the trials, those things were never really studied. We were more interested in, does the vaccine work? And so we just don't really have enough information to tell you how you will react and whether the vaccine is going to work. But we say that the vaccine is not infectious, the current ones, that is the Moderna and the Pfizer. So whereas I would tell you, I would not want you to get, for example, the measles vaccine or the live influenza vaccine. This is one that there probably is no reason why you cannot get And the choice will be yours whether you want to get it. But a priori, there should be no reason why it should be a risk to you. Recognizing the fact that we still just don't know exactly how people on immunosuppressing drugs will react to it. But there would not be the same risk that you would be in getting a live virus vaccine. And that we would tell you not to do. But I think this, recognize, is not a live virus vaccine.
Question, does the MMR vaccine provide any protection for COVID?
The answer to that is no. The MMR, which is measles, mumps, rubella, does not give you any cross protection against COVID. What people would like to think is that if you get an immune reaction to one virus, even though you're reacting specifically to that virus, maybe you're revving up the whole immune system, and so there'll be a little effect against literally everything else. But we say you can't count on that. So for practical purposes, the answer is no. There's no relationship between any of the other vaccines and this particular coronavirus.
Okay. If a person who gets COVID-19 vaccine has no side effects at all from the vaccination, are they as fully protected as those who get symptoms after the vaccination?
The answer to that question is we think they are. We don't know. I think it's always a very interesting question. And what I would say you could do if you had got no reaction at all, just have them measure your antibody. It's a very simple test. You get an answer back in a few minutes, literally. By the time it gets reported back to you, maybe a day. But have your doctor just measure your antibody and see if you have antibodies to the COVID virus, and you'll know. But yeah, I understand the concern, and I think many people have asked the same question, but there's no reason, say a priori, that you can say if you don't react with soreness or et cetera, that you're not immune.
Are we likely to require a booster dose of the Moderna vaccine or any other vaccine to take into account the variants that are coming now?
Yeah. These coronaviruses, like influenza, are RNA viruses, and they don't edit the RNA. So they, just like influenza, they keep on making mistakes. So this virus changes. It constantly evolves. And we're seeing that now. When we talk about the various strains from Great Britain or South America or Brazil, what we're seeing is the natural evolution of that virus. Now, so far, we have not seen convincingly a change that would say the vaccine is not going to work. There are some suggestions that some of these strain variations make the current vaccine less effective, but there's no data so far that says the current vaccines will not work. So because of the fact the virus is constantly evolving, the answer to that is yes, it's likely you will have to have another booster. That decision has not been made yet. We don't know the answer to that, but I think it's quite likely you're going to have a booster. And I'm told that in Europe, they're already telling people they need a third dose. And that's with the Pfizer vaccine.
Okay. Have studies been launched yet to understand the effectiveness of current COVID vaccines for people who are immunocompromised by immunological diseases and or being treated by immunotherapy?
Yeah. Again, the first studies that have been done, which include now, let's say 100,000 patients, all those studies were designed to see whether the vaccine was going to work or not. So they weren't interested in looking at people with particular problems. Now, there were some people like that got included, but there weren't enough to really make a decision as to whether or not it will work in immunosuppressed patients, patients with autoimmune disease, pregnant women, young children. We don't know any of the answers to those questions because we don't have the data yet. That data will be developed over the next year or so, But in truth, we just don't have the data to reliably answer that question so far.
Why is the flu seasonal while COVID is not?
Well, the reason for that in part is that the flu changes 3 times more rapidly than does COVID. So the flu makes a lot more mistakes in essence, and that allows it to change more rapidly. So flu changes every year. We think COVID is going to change, but doesn't seem to be able to change that rapidly. But I would not be surprised that you'll have to get a COVID booster maybe every 2 years or maybe every 3 years. Now, we don't know the answer to that yet. That's something we have to work out as we go in the future. But these, there are 2 things I would tell you about this virus that I might have mentioned before, but I didn't. And that is that viruses that enter your bloodstream, measles, chickenpox, mumps, yellow fever, if they enter your blood, typically the vaccines give you lifelong immunity. But viruses that exist on the surface, influenza, coronaviruses, adenovirus, those viruses typically give you immunity that only lasts a few years, and then it goes away. So you add together that fact, plus the fact the virus is changing, and then you say, very likely you're going to have to get a booster periodically. The only question is when, and that hasn't been worked out yet.
Given all the information we know about the vaccines so far, which is the best and most protective for those of us over 70 years old?
If you're asking about the coronavirus, what I would tell you is it's whatever you can get, because you won't have a choice right now. If you get assigned an appointment, remember, all this is done by appointments. You have to get online, sign up for the vaccine, and you'll be directed to a list of available appointments. You'll pick the one that's convenient, and they'll tell you where to go. And when you get they will tell you what they have to give you. So the coronavirus, you don't have a choice. It's whatever they have. If you ask me when you get to be 65, what vaccines you should get, it's the Tdap for tetanus and whooping cough. It is the shingles vaccine. It's the influenza vaccine. It's the pneumovax, and it's the coronavirus.
Do any of the vaccines have aluminum? And if so, what does it do to the body?
And to my knowledge, I don't know of any that have aluminum in. For a while, we were using mercury as a preservative. And that has largely been stopped. There are some that have, particularly this has to do with the influenza vaccines, have some very small trace of it, but almost all of them have eliminated mercury from the vaccine as a preservative. And if you need to know, then when you get the vaccine, you have to ask, and they'll have to check the label, because the issue of mercury has been a very sensitive issue with us in the medical community. But it's mercury, not aluminum, to my knowledge.
Can I mix the doses of the vaccines, Pfizer and Moderna, to complete the 2-dose requirement?
The answer to that is no, because the vaccines are slightly different. And we say that, and that's a very important question. It's on everybody's mind, but the vaccines are just different enough that we say we want you to receive the same vaccine. We do not want you to mix the 2 vaccines.
Since it's kept at a low temperature, how does that work when put into a warm body?
It's because the reason it works, because even though it's kept at such a cold temperature, the minute it gets in your body, the body heats it up to body temperature within minutes. In fact, maybe even within seconds. That RNA is taken up into your cells right away and disappears. You can't find it within about 2 or 3 days. It's already taken up and used. But it's heated up, and your body your body recognizes that it's able to do it, it has to do independent of the temperature that it was used to store the RNA.
If a person gets and recovers from a case of COVID-19, how long should they wait before getting the vaccine?
Well, we tell them that they don't have to wait at all. They can go ahead and get the vaccine. The only thing we want them to do is we want them to wait at least 10 days so they're not infectious for others when they're getting the vaccine. But we also say that we're pretty sure that if you have natural COVID, you are unlikely to get a second case for about 3 months. So you could wait up to 3 months before you got the vaccine. But in actual fact, the only thing we say is just make sure you are past the period of infection, because we don't want you in that line to get the vaccine if you're actually spreading the virus.
Okay. If the reaction is to the second dose is more severe, does that mean that you should get, if you get COVID-19 after being inoculated, will the reaction be even worse?
Well, we're hoping that it's the reverse. The reason we give you the vaccine is to modify the illness so you don't get a bad reaction when you get the illness itself. And that's what we know from the studies. Both Moderna and Pfizer have shown that if you get the vaccine, the chance that you're going to get a very severe case of coronavirus, being the COVID-19 disease, is much, much less, and may be after 2 doses, may be very close to zero. And we do know that from the studies.
In the past, with the flu vaccine, I always ask about my latex allergy to determine what vaccine to be given. Would that be a factor with the COVID vaccine?
The answer to that is no. The only thing that we say would be a concern is if you have reacted to the components of the vaccine itself. And the components of the vaccine, most important of which really are the fatty material that's used to protect the RNA. And now we're talking exclusively about the 2 vaccines that have been released so far, Moderna and Pfizer. And that's polyethylene glycol. So if you've reacted to polyethylene glycol or the related compounds we call polysorbates, then we have reason to believe that you could be allergic to this. And particularly if you had an anaphylactic reaction to those, we would say you should not get this vaccine. If you've had other allergies, we say be sensitive. And that is when you go there, wait for about 15 to 30 minutes to make sure. 15 minutes is probably all you need. Make sure you're okay. But your chance of reacting is very small. We're not worried about reactions to people who are allergic generally. But we do say if that is the case, we want you to hang around for at least 15 minutes so we can watch you. But otherwise, we're going to give you the vaccine. Recommend that you get the vaccine.
What was the name of the antibody test that you could get to make sure that it was effective in you?
You just ask for the antibody test for the coronavirus. It's different people do it different ways. The rapid test is actually an Abbott test, but you won't know what test they're going to do anyway. So all your doctor has to order is the antibody test, and you'll get whatever one they're using. And the rapid ones comes back positive or negative. And it's not even a quantitation like other antibodies are. You'll just know reactive or non-reactive is what it'll say. And if it says you're reactive, you have antibody.
Why is the natural immunity from COVID shorter lasting than from the vaccine?
That's a good question. And we actually do not know for sure that's the case. It looks like with the vaccine, you get more antibody than you do with the natural infection itself. And that may have to do with what we call the antigenic load. And that is that when you give the vaccine and you give this RNA, you may be producing many, many times more of the viral protein than you would get with a natural infection. And so for that reason, you may be developing a lot more antibody. But we don't actually know the answer to that question. But it is true that most of these vaccines have given you higher antibody levels than you get with the natural infection.
Okay, should you take Tylenol or Benadryl prior to receiving the vaccine?
That's another good question. And we say, don't do that. Take it afterward if you react. And the reason for that is really not very clear. It was based on a theory that if you give an anti-inflammatory beforehand, that you may diminish the immune response. There really is no evidence for that either. If you have to take it, you have to take it. Some of us, including myself, take an aspirin every day for cardiovascular reasons. And if you have to take it, take it. But if you don't have to take it, we say don't do it. Take it afterward when you see if you're going to react, like fever and chills and things like that.
When a person gets the COVID-19 disease, how long does a moderately severe case last?
Well, it varies. And the acute illness itself probably lasts about 2 days. You probably start to feel better on day 7 or 8. That's the average person. And remember, the way this thing works, that if you get the virus, in most cases, probably we would say 95% of the cases, you would get either nothing, or you will get a cold, which may be a minor cold or a very bad cold, bad cough, which could even be walking pneumonia. But it's that 5% of the cases that bring you to the hospital. And of those 5% that bring you to the hospital, maybe 1% of all the cases or less are going to end up in the intensive care. Between 0.5% and 1% are going to end up in the intensive care unit. And those are the people in whom the mortality is the highest. So when you say, how long does it take to recover? For the vast majority of people, it's going to be within 10 days. But the sicker you are, hospitalized patients, ICU patients, that can take a long time to recover. Now, the second thing is there's something we call long haulers. And those are people who get over the fever, but have a lot of fatigue, a lot of aches and pains, don't concentrate right. In days with other illness, we would call it chronic fatigue syndrome. There is a lot of that after COVID. So even though you get over the fever and the acute symptoms, there are a lot of residuals that come afterward. And we're still trying to figure out if some of the people, like the sickest ones, actually get enough damage that there may be some permanent complications that they may have to endure. But the vast majority of people are that 95% that are going to do okay and recover.
I want to thank you, Dr. Cesario, for coming and talking to us today.
Good. Are you very welcome? I'm delighted to have the opportunity to do it. And I hope that was helpful, and appreciate the interest and the concerns.
Okay. So our next lecture will be on February 3rd at 7 p.m. And the topic will be screening procedures for cancer. Also this Saturday at 9:30 in the morning, the Transitions and Retirement Series will be presenting Cleaning Out the Clutter and Hoarding. We hope to see you at these 2 classes, and stay safe and have a good week. Thank you.
Thank you all.
Thank you.
Thank you again.
Very informative. Thank you.
Yeah.